but we will keep the time for the speakers, of course. And let me start immediately to introduce the first speakers. And I'm particularly pleased to welcome those three speakers that comes from my country. They are good friends of mine, and especially talking about Luigi and Michele. They work together, they have a boat, and they go with the boat together. They have 2 and 3 children, so that means that they increase the average of the world population a lot. And about Roberto Pistilli, that is a good friend of mine, is a good surgeon, is working a lot about regenerative surgery techniques. They will introduce you a very interesting topic, and because they are so keen about sailing, we are really anxious to listen what is the trip you will do together now. So please, go ahead.
Good afternoon, everybody. Mauro, thank you very much for this nice presentation. And thanks to Megagen for inviting us in this wonderful place, in this wonderful family. I would like to start today's conference by asking ourselves which implant connection should we use in order to preserve aesthetics of the peri-implant tissue. We have 2 types of connection. One on the left is vertical connection that we call tube and tube. One on the right is an horizontal connection that we call flat-to-flat connection. The topics of today's lecture will be focusing on the advantage of using a conical connection in preserving the aesthetics of the peri-implant tissue. We can reach a good aesthetic result in the restoration of the natural teeth because we all know the guidelines in order to obtain heat. This is the reason why some years ago, instead of using an implant on a patient with high aesthetic expectation, we choose to replace the last tooth with a traditional restoration. We working on the tissue with an epithelium connective insertion, and we had a good result, as you can see in this slide. The final prosthetic restoration made the patient very satisfied, and the result was achieved, as we all knew the guidelines on how to work on natural teeth. As we are going to see in the next slide, this result depends on the tooth marginal fit of the crown, which must be extremely precise. Luigi and I are very affectionate to these optical microscope images, as they are part of a study we published in 1988 with our mentor, Professor Mario Martignoni. Here we can see a metal ceramic crown seal the tooth very well, and thanks to this precision, the biological width is well conserved and the tissues are stable. On the 2 images on the right, instead, we have a big gap between the crown and the tooth, and this leads to a repositioning biological width and a decrease of the soft tissue. But if we criticize when a crown is not precise, why? When we have no fit between an implant and abutment and also the reabsorption of the crestal bone, in literature we speak about physiological reabsorption of the bone. Let's not forget that the reabsorption around an implant, not like on the teeth, does not exist only vertically, but in a minor measure also horizontally. And this, for the aesthetic result, might be inconvenient. In literature, Herman's article distinguished the reabsorption of the crestal bone between the 1-piece implants and the 2-piece implants. In the 1-piece implants, the bone went to the rough, smooth interface. For this reason, it makes no sense to insert the smooth part of the implant under the bone. In fact, in this case, where we submerged the implant, hoping to hide, degrade the titanium, but, as we can see, in the rigs, it had no sense, because the bone went in the rough, smooth interface. The soft tissue followed the bone absorption, and this, in an aesthetic zone, is very dangerous. In the 2-piece implant, the classic Brånemark implant, the bone went 2 millimeters below the microgap implant abutment. For this reason, it makes no sense to insert the implant abutment connection under the bone, because otherwise we will have a 2 millimeters of absorption plus the millimeter that we submerged the implant. This is the case of a young patient who wanted to rehabilitate her anterior teeth with single crowns. We inserted an implant with flat-to-flat connection between two teeth, and today's result is apparently very good. But at a distance of 2 years from the implant insertion, we have a crestal bone reabsorption of about 2.5 millimeters. We still have stable soft tissue because we still have the peak of the bone next to the adjacent teeth. However, if we lose this, we will be in trouble. The patient is still very satisfied with our work, but who knows how it will end. So, if the question is which implant abutment connection should we use, the answer is that we want a biological connection with no bacterial microinfiltration, no micromovements, with a plateau switching, with a macrovidity until implant abutment interface, with subcrestal positioning, and with a concave profile abutment.
Speaking about the biological connection that we want to introduce you, the first step is not to have micro leakage in the implant abutment connection. The key factor is the micro gap between the implant and the abutment. And in this case, we have two kinds of micro gap. One generated from horizontal interface, flat to flat, and one to vertical interface, tube in tube. One of the things that, considering the gap, an older scientific work of Byrne, we can realize that the flat-to-flat interface is really very open. So it's impossible to close this gap with this kind of interface. Dibart has been the first to demonstrate that a conical connection could be very tight to bacteria infiltration. In our department, we analyzed scientifically the microinfiltration in different implant systems, and now we show the first step, that is the optical microscope analysis. We took 4 flat-to-flat connection systems, you see on this scheme, and 6 tube-and-tube connection systems, closed with recommended torque, and we analyzed them. These are the images, optical images from flat-to-flat connection, a Branemax system, a replace system. You can see how is big the microgap we have in this case. Also in 3i, the microgap in this case, the best in the flat-to-flat is the Xi, because as a bevel in the implant abutment connection, but the situation changed dramatically with the tube-in-tube connection, because you can see how is different the kind of microgap you can have in this connection. Straumann bone level, Nobel Active, Astra, Ankylos, EZ Plus, and Ridge. The final consideration we can do that the tube-in-tube connections have really less gap related to the flat-flat ones because of their geometry.
In the second study, we will see the analysis of microgap with the scanning electron microscope. This microscope allows us to obtain enlargement until 20,000. We took 4 implant abutments for each system, and on each of these we did 6 random measurements, obtaining 24 observation points for each implant abutment connection. After metal coating, the samples were positioned in the same observation chamber, allowing the gap to be perpendicular to the observation axis. If we see these images at 40 enlargement, apparently we have no gap. But if we see these images at 20,000 enlargement, we see big gap of about 11.8 for Nobel Replace, 10.5 for Nobel Branemax, and 5.5 for 3i. No gap at 40 enlargement for Xi, Nobel Active, and bone level. 20,000 enlargement, there is a gap that is less, 3.4 for Xi, 1.9 for Nobel Active, 1.6 for bone level. No gap for this conical connection at 40 enlargement, a small gap at 20,000 enlargement. Only 1.5 for Astra, 1.25 for Ankylos, and only 1.5 for Megagen EZ+. The third exam that we did to check the implant abutment connection precision is called fluid filtration. It stands in putting under pressure the implant abutment system and controlling if we have a fluid loss from the connection. The implant and abutment sample have been joined together with the resin, and after we took off the screw to insert the fluid. The result was that all the conical connection didn't have fluid loss. Instead, the flat-to-flat connection had a fluid loss that went from 1 mm for Xi to 14 mm for Brånemark. The fact that the conical connection didn't have fluid loss proves that every titanium cone, even if, as we saw with the SEM, there is a small gap at the top, has inside some points where implant and abutment seal.
One of the final investigations in this field we performed in these years is an in vitro study on the micro-leakage of different implant-abutment interface, where we submerged the samples in a broth containing 3 bacteria and 2 types of candida to analyze the seal of the connections. After 15 days, we removed the abutment and we performed 2 swabs, one in the connection and the other in the screw, to control the presence of microinfiltration. We also performed a SEM analysis in order to visualize the presence of a microorganism organized like biofilm. You can see a biofilm organized in your right presentation. The results shows how the conical connection have a better seal than the flat-to-flat ones, even for bacteria than for candida microinfiltration. But one important thing, the interesting fact is that if we do not use the recommended torque, all the systems do not perform well, and all the samples were infiltrated. This is very important from a clinical point of view, because the recommended torque activates the connection. This is important in a conical connection, to activate it.
Second point of biological connection is no micromovements. In this video, made by Professor Paul Weigel from University of Frankfurt, we can see how, on the left, with a 30 degree of axis loading on 380 Newton, the flat-to-flat connection opens from the side where the abutment is loaded. And this doesn't occur instead on the right in the conical connection. That if we see this optical microscope image, we see that in the flat-to-flat connection we have a big space inside. We have no contact between implant and abutment, and all the retention is on the screw. Things change completely with the conical connection, where we have a contact between implant and abutment that allows the opening of the connection. This for ball level, for Nobel Active, for Astra, Ankylos, the sample that we examined for EZ Plus and any ridge. But very important for us is the comparison of the conical connection. We always speak about conical connection, but a thing is a conical connection of 16 degrees, and another is one of 5 degrees that is really more retentive. We have the same situation with the height of the cone. There is a very big difference between a 1.9 millimeter cone and one of 0.7 millimeters. That will be less retentive. Another exam used to study the internal of the connection and useful to see if there is a contact between implant and abutment is macro CT sky scan. In the video, you will see how we will analyze the connection starting from the beginning to the top. The first video starting is the Brånemark system. You can see that there is a white space between the implant and abutment. That means that we have no contact. The same for the Nobel replace. White space between implant and abutment. We have no contact. All the retention is... Sorry, but we have some problem. Again. Okay. All the retention for 3i is on the screw. Things change with conical connection. the first starting is the noble active. We have a space in the bottom of the implant where there is the index always not working, but when the con starts, not now, okay, now for a brief instant is all gray because we have a contact. The same for Straumann, we have the index, no contact in the index, we have an index with, now with 4 position, and when the con starts, now we have all gray, that means we have contact. With Astra, we have an index with 12 position, with a white space, not working. Now, in a second. This is the index. And when the con starts, now we have a long gray period. That means that we have a longer con. The same for Ankylos, where we have 6 position index, not working. And now, when the con starts, in this second, we have a long gray period because we have a long con. So, stopped. The SkyScan analyzed the video and give us a numerical value from the contact area of the connection in square millimeters. Where we have the little red point, we can see that Ankylos and Astra have a bigger contact than the others.
The third point of a real biological connection is the Platon switching. This is the presence of a Platon switching that has the biological function of shifting the possible gap far from the bone and mechanically to concentrate the load far from cortical bone following the inner part of implant, like we can see in this study, where is evident from this finite element analysis how the load is concentrated in the middle of the implant, on the right platform model, while on the left, that shows a normal model, is concentrated at the implant cortical bone interface that can realize a bone overload in that point. With an optical analysis, we studied how different commercial systems have a different approach to realize a platform. We see different approaches to realize a platform switching, 3i, Nobel, with different length and different angle in the platform. Astra, Ankylos, EZ, Ridge, all the summary shows how different can be the platform in terms of length and angle. Different ways to probably reach the same results, to have something with this kind of situation. The fourth point could be important to allow the bone growth on the platform. It is the micro-ruvidity till implant abutment interface that is strictly related to the subcrestal positioning of the implant. As an IMPRESS research that we performed, we studied the performance of different subcrestal positioning of implants with a conical connection. The results are that the 2 millimeter subcrestal is probably the best compromise in terms of biomechanics. Here you can see different positioning under the bone. This is what we want. The histological sample shows that it is really possible to have bone on the platform. But, in fact, in our work of 2008 on Journal Prosthetic Dentistry, we compared the biomechanical performance between traditional implants with resorption cone towards implant with conical interface and subcrestal positioning and the bone on the platform. We do this comparison with a fair finite element analysis study. We designed the different bone interface condition, one with bone on the platform and one with a cone of resorption. And the results is very important, shows the better performance in the load transfer, even in the compressive and tensile forces on your right, of the implants with bone on the platform and conical connection. This is a dramatic change. The behavior of the implants with this kind of condition is completely biomechanically speaking different. To validate the biomechanical difference with or without subcrestal positioning, we compare the same conical connection implant with a statical mechanical test. In the movie, we can see as an implant positioned 1.5 millimeters below the bone, that is the requirement of the ISO test. In this condition, we have a breaking load of 3,376 newtons. And if we analyze the stereo microscope images on the right, we can see that with a right conical connection, we have a deformation of the implant that allows the abutment to be ejected under load. We also have the deformation of the screw and not of the conical part of the abutment. This because we have a great friction between the conical part of the abutment and the implant. The same test, we performed the same test with 2 millimeters of subcrestal positioning. That shows that the breaking load grows to 609 newtons, increasing more than 60% considering the test without bone on the platform. And for this reason, we do not have the same deformation you see on your right in the implant diameter as in the stereo microscope images. So a big difference to have bone on the platform or implant outside the bone. And as in the previous test, also the deformation screw is on the screw and not in the conical part of the abutment.
A 6th point of the ideal implant abutment connection is the concal profile abutment. I consider it as very important for the tissue stability because we think that with the concal profile abutment we can optimize the result, increasing the width of the connective tissue, and this in an aesthetic zone is very important. We saw, in fact, that we could have an horizontal attachment of the connective on this abutment instead of the vertical attachment that we are used to see around our implant. This is what we can see on these images of friend of ours, Marco De Gidi and Adriano Piattelli. This histology is about a rotation on humans, not dogs. We think that with the macro design of the transmucosal components, we can have a mechanical stabilization of the soft tissue, because with the concal profile abutment we have an important soft tissues width. And if while taking off the inner abutment we see blood, that means we had an attachment. And if we repeat this a lot of times, we will have no more blood because there is a scar. So please do not change abutment many times. The advantage of this type of abutment is described in Rompen's article published in Journal of Prosthetic Dentistry, demonstrate how 54 implants with concal profile abutments placed in a one-stage approach with immediate function, gingival level remains stable at 12, 18 and 24 months. We have a vertical gain in 53%, stability of the tissue 33%, recession only in 13% and all with less than 0.5 millimeters. If we compare this result to the ones of Small and Ternau published in JOMI, where they use an abutment with divergent profile, we can see that they had a buccal recession on the 80% of the cases, always between 0.5 to 1.5 millimeters. These results are much worse respect Rompen's one with converging profile abutment. So, what will change at the clinical level if we use a conical connection? First of all, we can insert the implants closer than 1.5 millimeter, as the literature advises us, because by not having the reabsorption of the crestal bone, we do not have a vertical soft tissue limitation. It's the case of this young woman. The orthodontist does not leave many space to insert the implant, but even if we insert our implant so close to the teeth, we still have a nice aesthetic result. We use the immediate loading with a concal profile abutment. The final manufacture and the check after 2 years demonstrate that we did not have the reabsorption of the crestal bone and no loss of the soft tissue, even if the implant was so close to the teeth. The follow-up after 7 years. Another case after the orthodontic therapy where we inserted the implant close to the teeth. I inserted the implant with immediate loading and made a soft tissue augmentation at the same time. On the right, I made a pouch graft, and on the left, a roll technique trying to increase the width of the tissue. Sorry, on the left is pouch graft, and on the right, a roll technique. The provisional restoration, the RX control, where we can see the subcrestal implant position and the very close teeth. 15 days after control. 6 months after control with the final restoration, where we can see how both sides had a good healing of the soft tissue regardless the regenerative technique used. The follow-up 3 years after with the maintenance of the soft tissue. In this other case, we have an included canine that we extracted and then inserted the implant at the same time. The healed tissues, provisional crowns, and the final result stable after 4 years. We have a second chance at a clinical level if you use a biological connection. We can insert the implant closer than 3 millimeters from one another, as the literature advises us, even though we don't have the loss of the peak of the inter-implant bone because we don't have the reabsorption cone. It's the case where we extracted the upper right premolars, bone regeneration with BIOS and the absorbable membrane, 6 months after we inserted the implants, completing the rehabilitation after 3 months. The health of the soft tissue is very good 6 years after. We don't have crestal bone loss. Even better, we have a growth of the bone on the platform, even if you can notice on the RX that the inter-implant distance is less than 2 millimeters. We are observing another case where we inserted 2 implants near one another. Our patient was not satisfied of his mild aesthetic line. The 2 central incisors were mobile. They proved 11 millimeters. The patient has been rehabilitated with 7 teeth instead of 6. We simulated the diagnostic workup for a right aesthetic rehabilitation. We insert the implant, not worrying about the occlusion between them. At the same time, in able to reduce the buccal depression, we execute a modified roll technique, enlarging so the connective tissue in that zone. At this point, in able to build a good occlusion on the patient, I'm having an electronic axiography to insert correctly the casts on the articulator and setting it by the values obtained. The final result, the RX control after 3 years, where we can see that even if we have a 2 millimeter distance, we don't have a crestal bone loss. In this patient, we extracted the upper first and second incisive and included canine. After 6 weeks from the extraction, we inserted the implant, an important bone defect. In this case, we used a bone tissue augmentation with the osteosynthesis plates and a double reabsorbable membrane fixed with pins. Periosteoplastic flap for a better closure. After 6 months, we open again for removing the plate and the pins, and you can see that we obtain a good bone regeneration. We inserted the healing abutment, and we took a connective graft from the palate, inserting it in the buccal depression. The provisional restoration. The final rehabilitation 6 months later. Comparing it with the initial situation, we obtained an increase of the soft tissue. So, in conclusion, our goal will be, if possible, immediate loading, one abutment, one time, allowing the tissue to heal around our crowns. We can see it in this rehabilitation of the first upper quadrant, where we inserted the implants, the abutments, and the temporary crowns in the same day. The temporary crowns after 3 months. The definitive crown after 6 years from the insertion. We can observe the good health of our hard and soft tissue around the manufacture.
Good afternoon to all of you. Thank you, Mauro, for your presentation. I will show some clinical case, but first I wish to thank Dr. Park, St. Matthew, for inviting me in this wonderful place and also for making available to us clinicians a series of implant systems like this that are such reliable to assure an ideal solution for every clinical condition. Like in this case, we can see a severe atrophic bone, vertical bone atrophy in the inferior incisor area, in which we decided to perform an inlay technique, and after preparing the crestal bone box, we raised it about 8 millimeters and we stabilized it by interposing a bovine bone block. In this way, we obtain, after 4 months, a big amount of bone that allowed us to place 2 A-zeta implants that still have an optimal stability 3 years after loading. In this other case, we have a severe post-traumatic atrophy of the maxilla, in which we don't have any chance of placing an implant. And the only thing we can do is a sinus lift in conjunction with an only autologous bone block grafted from the iliac crest. And this is the second stage after 3 months. We can observe the volumetric augmentation of the ridge that allows us to place 6 implants supporting an orthopedic prosthesis that restores the smile in this young lady. In this other case, we are in the same area, but we have more bone. We can solve more easily this case, raising a mixed thickness flap, both full and partial. Full in the molar area, where we perform just a crestal sinus lift with the technique developed by my friend Samuel Lee, and placing an implant at the same time. While in the premolar area, we augment the horizontal dimension, performing a split crest with a Curie disc and enlarging with 2 chisels in order to place 2 A-zeta implants that are able to stabilize the bone increment. You can see and look such a good quality of bone we managed to obtain. And look at the quality of the soft tissue. And this is the final prosthesis, rehabilitation, and the RX control after 1 year of loading. But not always the patient's condition can allow us to perform an augmentation technique, both for general reason or because the maxillary sinus must be avoided for local inflammation. You can use computer guide, yes I know, but I prefer to draw on the bone the anatomy of the maxillary sinus, and then after placing 2 implants in the premolar area, I tilt the drill distally and then I position the implant, avoiding in this way the maxillary sinus itself. This is a post-sinus tilted implant. In this case of bilateral atrophy, we have made a different choice. On the right side, we have placed 3 short implants, 3 rescue implants, while on the contralateral side, we perform a lateral sinus lift, and we placed 4 A-zeta implants. And you can see the control after 3 years of loading. But I wish to go back and talk again and more in detail about the Samuel Lee sinus lift kit a really smart kit in which we have a soft approach to the sinus floor and to the sinus membrane. With these suitable elevators, we raise the membrane and we insert a certain amount of biomaterial and then the implant. And you can see the control after 2 years of loading. But I believe that the greatest gift that Megagen gave us is the AnyReach implant, that more than any other is suitable to the Gressel sinus lift technique, because its apical shape and its aggressive threads push up the biomaterial and the sinus membrane itself in the most efficient way, as you can see on the RX after 1 year of loading. And this is the demonstration that AnyReach is the most suitable implant for Gressel sinus lift. When I use AnyReach, and now I use only AnyReach in Gressel sinus lift, I don't remove this semilunar bone fragment, because the round-shaped tip of the apex with its first threads fractures the semilunar bone fragment and it pushes it up together with the biomaterial, and you can see after 1 year that the new floor of the sinus is perfectly corticalized. Nevertheless, you can use this implant AnyReach in a lot of other conditions. Now we are going to see the last two cases with two different prostheses, because they had two different starting conditions. In the first case, even if we have an optimal clinical condition, the patient had a total removable denture for many years and had already lost much of the vertical ridge dimension. We placed the implants, second stage, after 2 months. We open, and you can see the good quality of the soft tissue and the radiographic control of the prosthetic connection. And this is the clinical evaluation of the orthopedic prosthesis and the radiographic control after 2 years, where you can appreciate the perfectly maintained bone between the implants. Look at the bone peak between the implants. And this is the second case in which we planned an immediate implant placement after the extraction. Even if we can't avoid losing the bundle bone, using the biomaterial help us maintaining the buccal bone profiles. And also, as you can see, we put some more biomaterial on the buccal bone plate and we covered it with a collagen membrane. We decided not to place the implants in the central incisor area because that is the most critical aesthetic area, which we will restore with a connective tissue graft. This is the control after 4 months. Then we use a soft tissue graft to correct this deficiency in the mid area. We use an oval shape reduced provisional prosthesis for the soft tissue conditioning. And this is the reevaluation after 2 weeks on the left side, when we removed the sutures. And this is the prosthetic finalization, with the clinical and radiographic reevaluation 8 months after loading. And now I let Luigi and Michele take the floor for the final remarks. Thank you.
So, in conclusion, what do you think? Can it be the conical connection the key factor in preserving the aesthetics of the pre-implant tissue? We think so, because we demonstrate that with conical connection we can reduce the crestal bone reabsorption. We can insert the implants between one another, so we can reduce the distance between adjacent implants. We can have a system that absorbs better mechanical stress. We can use more implant for big crown. And this is very important for us in the molar zone, where we can use a diameter of 3.5 for a big crown, because we have a very strong connection. We can use the emergency profile that we like, because we are far from the connection, because we insert the implant under the bone. We have a strong connection, so we can use single crown. And least but not last, we can, with our concave profile abutment, we can have a soft tissue augmentation. And this is very important in our aesthetic zone, and is very important because can preserve the perimplantitis.
So the new age of implantology is to achieve a conical connection. That is not only subcrestal positioning, concave profile, microruvidity, platform switching, is a concept that is all inside. So we want a biological integrated system that functions in our mouth, in our patient. And you can see how we perform our optical microscope analysis. On the left, N-ridge, and on your right is 8+. What is the future in our research? Are in the immunology responses at dental implants, studying the epithelial responses near the implant abutment junction and the abutment crown junction. These are epithelial cells on your left with plaque. This is in the center an epithelial cell that is expressing an inflammatory response in the membrane. And this epithelial cells was towards an implant. So, thank you everybody for your attention.
Chris Chang. Well, I don't talk, once again, I don't mention the CV, you can read it in the book. I don't mention about the abstract, you can read as well. What I can mention about Chris is that he's playing violin, that he's a good golf player, and moreover is a keen of informatics, and that's something that makes me shocked because, I'm some problems also to switch on my PC. So to see what he's able to do is something that is astonishing me so much. And he has done a great job of 6 books with an interactive system, and moreover is really fanatic about presentation techniques. And let me use one second to let you know that one of the main points of the speakers is to keep their presentation interesting to the audience. So actually I'm really pleased to introduce you Chris, and I'm really impatient to listen his surely interesting presentation. Chris, it's your turn.
Thank you. Thank you, Professor LaBanca, for your kind introduction. It is a great honor to speak here, and I feel like come home and see a lot of good friends. And the video you saw on the screen is my office, and you're welcome to visit my office anytime you visit Taiwan. So, I think it's appropriate that I give you a little bit idea about where I come from. I come from a small island by the name of Taiwan, and it was surrounded by Hong Kong, China, Korea, Japan, and Philippines. And when I look at in this perspective, I realize that my hometown actually is the center of the universe. That was amazing. And one time I was Google and figured out the tallest building on earth actually was in this small island by the name of Taipei 101. And certainly it was the second right now, second to the Dubai Tower. So if you went to the Taipei city, and my office Beethoven was 60 miles south of Taipei 101. So welcome you to visit Taiwan. And I want to pay my special thanks to Dr. Park and his organizing committee. It is very difficult to organize a meeting like this. And from my very dear of my heart, Dr. Park is my mentor in implantology. And I was so lucky to know Dr. Park a couple years ago, and I learned a lot from him. So today, I'm going to talk about how to connect ortho and implant, these two specialties together. And let me give you my belief. I truly believe in case study. We can talk about literature, evidence-based a lot, but I want to see the case. So in order to present my idea, I will use case by case to show you what I did in my office. And how I did it is did with three approaches. Number one, every case we review. So every case we take photo. Number two, every key step we review. If there is any wrong with that, be brutally honest to right our wrong. I want to correct the mistake. I'm not going to let the mistake happen over and over. So that's the way I study my case. So go back to the thinking process for also implant. That is my topic today. Why it's important? When I did a survey, I figured out that 8% of my practice have some sort of ortho and implant connect. And most of them, it's just use simple, very easy orthodontic mechanic to set up a situation so the implantology can put an implant within 10 minutes or 5 minutes. So think about use 2 or 3 years to do it also, and finally we want to set up a perfect situation to put an implant. So let me give you my first case. We talk about treatment plan. This 22 years old young lady went to 4 offices before she visited my office. And all of the orthodontic in my city propose a treatment plan like this. They want to take the third molar out. They want to push the second molar backward and put a dental implant. But that is not this young lady want. So she didn't like this treatment approach. Instead, what happened in her mind is she wanted to have the second molar protract forward to close the space and upright the third molar. In other words, she didn't want any implant, sorry. So there is no any reach right here. And that's her treatment plan because she has been Googled it and she exactly know that can be done. But unfortunately, 4 orthodontists ahead of me, they say it is impossible to do that. And that's her plan. So she was told that by these 4 doctors, it is impossible. So we go ahead, want to find out how to treat it. And there are 2 tips to do that. Number 1, you close the space first. After you close the space, the servomotor will automatically upright it. And after that, you'll be able to put your imprint, your servomotor bracket right there. So we upright it, and we close the space first, and we upright it. So within 11 months in treatment, you'll be able to close the space. And if you pay attention to the servomotor upright by itself. So it's time ready to put your bracket, which is perpendicular to the long axis of the servomotor. So with that, how to close the space? The mechanic I use actually is very simple, that I believe everybody in this room will be able to do that. I almost always use power chain. It's an elastic chain. So with this chain, because it's elastic, it produces a force. So it will be able to drive these tools together to close the space. So I use Hooke's law. And after I apply the power chain, then it produces a Newton's law. I follow the Newton's law number 3 and number 1. Number 3 is you apply the force, they can create the other opposite and equal force. And number 1 is after that, you reach the equilibrium. So all the mechanism that I use in my clinic, I use these 3 laws. So the second tip I'm going to talk about is, after you bound the bracket, you'll be able to put an open coil spring between second and servomotor. Why you want to do that? Because you wanted to keep the crown backward and bring the root tip forward, so you get a parallel of the servomotor. In order to do that, I would suggest you to put the second motor is a self-ligated bracket. It will be easy for you to open the bracket. So within 14 months, you will see that the major problem has been solved. So, ladies and gentlemen, believe me, it is easy to solve this problem. Every time I show you my face, I tell you from the very deep of my heart, it is easy. So with that, and I later figured out that this young lady actually described the whole consultation process from this 5 orthodontic, and that really put the previous 4 orthodontic in a very bad situation, because in her talk, he was discussing every detail, how I treat the case, why it's possible to treat this kind of case. And she also provided the other service. If you have a patient photo, you can just send to her website, and she can do the diagnosis for you. And remember, she's just 22 years old, did not get any dental education. She just used common sense to solve the problem. So, if the message here is, if you can, then you have to learn. Do not just say it is impossible. That's why the reason we get together right here to learn more about how to solve different cases. So in internet, no place to hide. We are all naked. So the message is, you really have to provide an option for that. So to conclude the first section, I think if I have a chance, my first choice would be avoid any implant. In other words, I don't want any implant. I want a 0 implant in all my cases. But unfortunately, even I prefer minimally invasive, but in reality, it is impossible. Because a lot of cases, they lose a lot of teeth. So what's the percentage of various cases that I treat with combination of ortho and implant therapy? I did a survey and find out a very interesting pie chart The reason why I like pie chart is I can give you the roadmap, so you know where I'm going to. First, I figured out that 60% of my case is just do space redistribution, which is easy, use power chain. And 20% we are dealing with interocclusal space adjustment. Sometimes you lose the antagonist and the two super erupt, you cannot do the imprint. The third one, we do implant site development, and finally that's etc. and etc. So if you can cover these 4 categories, I'm pretty sure that most of the case you can handle it. And remember, it is not easy, it's not difficult. So if you want to find out the material, you can go to my website, go to Google and type Newton's A0301. You'll be able to see those materials. So to conclude, the law we use Hooke's law. We use Newton's law number 1 and number 2, which we already learned from high school. Let's get to the second part, interocclusal space adjustment. So, suppose you have a case like this. Can you see the second molar? Actually, is hanging down and touch the lower ridge. And it's quite common in my country. So how do you solve the problem? The way I try to solve is I wanted to close the space and I wanted to intrude the second molar. But it is 6 millimeters down below. How do you solve the problem? So with that, I'm going to show you with the new technology we use the mini screw. It will be easy for you, for everybody in this room to solve this problem. So the simple way is we put 2 mini screws, one in the barcode, one in the lingual, and hook up the power chain that I already showed you before. And within short period of time, we're talking about 5 months later, we intrude 6 millimeters. So you're ready to put a dental implant down below. And after that, what I would suggest you is after you intrude, you need to hold the other 6 months. Why you need to hold the other 6 months? Because with the intrusion, the reorganization of gingival fiber takes time. So don't just debond it. But during these 6 months, you can also close the space. So it's hard to believe that 11 months in treatment, we'll be able to intrude 6 millimeters and close the space. So it will be easy for you to perform a dental implant down below. It's right here. It's hard to believe. So with school, there are many ways to solve this kind of problem. So you can improvise with different approach if the theory is wrong, is right. So let me give you the other example. Take a step further. Suppose you have low sinus flow. How do you put a screw into the sinus? Like this. When people lose the teeth, usually they will end up with pneumatization, and also because no occlusal loading, that will end up bone resorption. So finally, you will end up with very thin ridge. So she was told that it is impossible to put screw on her. You have to put on, okay? So, believe me, it is easy. So let me show you how easy we can solve this problem. It looks like pretty complicated, but if you think through the process, it actually is not difficult. First, you make an indentation with an Explorer. After you make an indentation with the Pro, and you follow that indentation, put this mini screw. So it's by cortical horizontal insertion. If you put like this, it will poke into the sinus. The screw won't stay. So why not change the direction, become buccal and lingual? So you'll be able to catch the buccal plate and lingual plate. With that, you'll be able to hold this screw. And what I'm going to tell you here is 100% of my screw used in posterior. I use 2 by 12 millimeter. It is stainless steel because you don't need austere integration. All you need is mechanical locking. So within 30 seconds, you'll be able to finish this screw. And next step will be hook up the power chain. And the serial for the power chain, the mechanism for the power chain is Hooke's law and Newton's law number 1 and number 3. So with that, you'll be able to intrude it and also a little bit backward movement of this elongated motor. So within a short period of time, used to be 1.5 millimeter, and 8 months later, we get 9 millimeter interocclusal space. And the top, we have 1 millimeter, and 9 months later, we be able to get 9 millimeter interocclusal space. So we solve this very, very difficult situation. So the law here is always Hooke's law and Newton's law. So with that, let's go to the next step. Suppose you know how to intrude this motor. You already know how to intrude it. And the next step will be how to put an implant down below. And suppose we didn't do also, then the huge gap, it will be difficult for you to put an implant down below. But without orthodontic, you probably need to cut the crown, and then you do the root canal therapy, and do surgical crown lengthening, and new crown, put a new crown. But I don't think this is a minimal invasive. So what I really prefer would be to do a simple orthodontic treatment. That will be minimal invasive. So for step-by-step for implant position, I would like to go back to the basic and show you how we position the implant. We've been talking about the basic of implant position. What would you put the implant in this case? Well, the next key step will be decide the position. You can put right here, or you can put down below. What would be the guideline? And there are 2 guidelines for that. Number 1, surgically driven. Number 2, prosthetically driven. So let's go to the surgical driven. Suppose you have these 3 situations, and according to the bone, you open up, you probably put an implant right there. And if you put an implant right there, and you preserve 3 millimeter biology width, your crown margin probably end up with here, and it will have long or short crown. And I think the patient will not appreciate you put a long crown or short crown like this. So what they really want, probably something in the middle. But think about how to produce a crown like this. So we go to the second approach, which is prosthetically driven. And we need to know the distance from surgical margin to the level of the bone. Suppose we put the crown margin right here, and we need to have 2 millimeter biologic width. So the implant position will be somewhere like this. And then, in the first case, you know, in order to produce an ideal prosthesis, you need to do is to put a bone grafting in the first case. But in the last case, you probably need to reduce the bone. And quite often, in orthodontic treatment case, most of the case, you probably need to reduce the bone. And a lot of people ignore this fact, so they end up with very short clinical crown. So for most orthodontic case, especially in this case, you need to grab a high speed and grind the bone. So you produce ideal bone situation to put this implant in the ideal position. So finally, you'll be able to produce an ideal crown. But the next step will be, well, I know, but how to transfer this information from model to intraoral? And the key is to use surgical stent. In my clinic, we use surgical stent in every single case. Even it's very simple case, we still use this surgical stent. So when you use the surgical stent, the key point is we use this surgical stent for you to recognize where you want to put the implant label. So the prosthetic driven is put this surgical stent, and we know when we want to build up the ideal crown margin, the restoration will have distal mesial and buccolingual, and we recognize the occlusal plane is there, and with cervical margin and the bone label, so we know the 3 millimeter rule, we need to put this implant right here in order to achieve the ideal implant position. So you may ask, is there any rule for ideal implant placement which have evidence-based, biological evidence-based? Let me walk through this for you. Suppose you've got a Combin CT, and from this Combin CT, you realize that the most useful will be slide view. So you realize you need to cut 4 millimeter bone in order to get ideal position. So this 4 millimeter bone reduction will be right there. So we know that where is the biologic evidence? The biological evidence actually published about over 50 years ago, and we know that for the natural tooth, we need to have a biologic which is connecting junctional epithelial and connective tissue, and we also need about 1 millimeter sulcus depth. So with this, and it comes up with about 3 millimeter. So in the biology, we have bone label right here. We need a connective tissue 1 millimeter, junction epithelial 1 millimeter, and 1 millimeter sulcus depth. So with that, we put them together. So we know if we want to put a crown, the crown margin is right here. From this crown margin, we want to have 3 millimeter apical to the margin, and end up with 3 millimeter from the crown margin. So we know the implant is 3 millimeter from the cervical margin and apical direction. So the second, we need to decide, we know the biologic ways. The next will be how far from the labial surface to the implant position. And we know that based on a lot of study, people have been suggest that 2 millimeter buccal bone thickness might be a good idea to preserve the bone structure and also sustain the soft tissue. So if you Google, probably the most famous article that I love a lot is Uli Grander put in 2005. This is a wonderful article to talk about why he want to preserve 2 millimeter buccal bone thickness. And they also have something, Fernando Rojas Vizcaya also execute this a lot. So we come up with 2 millimeter buccal thickness with 3 millimeter depth. That is the place we want to put our implant. So we go ahead, run through every procedure to make sure that we follow this basic rule. We use this simple surgical stent. We know from here we need to cut 4 millimeter bone out. And after that, look at that, it will be difficult for people to cut the bone, because in this room we all talk about to build the bone, do the bone grafting. So the implant position, we come up with a guideline like this. For the mesial distal, we put in the central. Buccal-lingual, we want a 2 millimeter buccal bone thickness. And the depth, we want to have 3 millimeter. For the angulation, the maxima will be 15, and the distance to the tooth will be about 1.5 millimeter. So based on this 2B 3D rule, we'll be able to locate the implant right here. And why we want to do that? Because the wider, the thicker your buccal bone, then the more blood supply you can get. And also the structural stability for the buccal bone. So I have learned that for years from Dr. Parr and from other people. So preserve this 2 millimeter buccal bone is crucial for that. So after that, we go ahead and put this implant 3 millimeter depth. So the implant will be 3 millimeter depth. But if you don't have the surgical stent, how can you know it's 3 millimeter from your future possessive crown? You cannot. So with this approach, we know the sound biological evidence. With the simple approach, you'll be able to achieve the ideal position for this simple dental implant. So 2B 3D rule is the rule which we use in our clinic for every single case if we want to get a good prosthesis design. So 2 millimeter buccal bone thickness, and with that we'll be able to position this bracket, this dental implant. So let's move to the third category, which is implant site development. So we start with the law. Suppose you have a case like this, and unfortunately the patient wanted to close all the space, and after the endo treatment, the general dentist told me the endo has been failed. So we needed to take out the left third molar. So the plan is to put the low depth first molar replaced with a dental implant and close all the space except this first molar. So with that, we are doing a space redistribution. Look at that third molar, mesial tilt. Within 30 months, we'll be able to upright and close the space. And the other side, we have the first molar, very, very narrow ridge. So what we did is, instead of do a bone splitting, we try to move the second premolar backward and create the implant site between first and second molar. So within 30 months, with this power chain, the mechanic, we'll be able to develop an implant site like this, so the patient can avoid do some bone splitting or some bone graft, something like that. So it's implant site development. So let's go back to the mechanic we close the space. I like to use buccal-lingual mechanic to close all kind of space, which is run the power chain buccally and also lingually, like this. For the left-hand side, we're going to add an open coil spring right here to create a space. So the way we did it is we use this 9-tie spring, open coil spring, and then we squeeze to here. And actually it's quite easy. So it's a kind of piece of 9-tie spring a little bit longer than the space in the bracket distance, and just squeeze in. So you'll be able to see that used to be a very narrow ridge. But when you slowly move the second premolar backward, you'll be able to create an ideal ridge between the first and second molar. With this approach, I think you can avoid a lot of invasive approach. So within short period of time, finally, we get an ideal reach to put this ideal implant position. And the implant I put is 4.8 by 12, which is a little bit too big. Today, but even I use 4.8, I still preserve 2 millimeter buccal bone thickness. That tell you, with the orthodontic approach, you really can save a lot of invasive approach. So, with the surgical stent, we know that 3 millimeter depth might be the way to go. So, this is a 2B 3D rule for this case. So, with that, so in this case, if today I probably just took 4.3 should be enough, but I just show you how much we increase the bone level from here to here. So go back to the basic. If I want to summarize the mechanic I use and the philosophy I use in this case will be when we have natural tooth and we look at outside in, you probably appreciate that we have mucosa, junctional epithelium, and attached gingiva, and free gingival margin. But if we look at inside out, which is more critical, you get 1 millimeter circular step with 1 millimeter junctional epithelium and 1 millimeter connective tissue. One day, when we lose the tooth and we replace with the implant, and you will end up with, you need to mimic the natural tooth, which is to preserve 3 millimeter depth of biology width. But the next question will be, why we need a 2 millimeter buccal bone thickness? The reason is, when we have natural tooth, we have the PDL. And the blood supply to the marginal gingiva will be by 4 different ways. First, from the PDL, and second, from the alveolar bone to the PDL. And number 3, from the cortical bone, and finally, from the apical mucosa to the marginal gingiva. And one day, when we lose the tooth, we no longer have the PDL. So we no longer have the 1 and 2 supplies. The only depth is number 3 and number 4. That's why we need to have a bigger bone, a thicker bone for structural support and for blood supply. And I have put all the material in this journal, the International Journal of Orthodontic and Implantology. And if you are interested in this material, the 2B 3D rule for the ideal implant placement, you can look at, download it. All the material I talk about today can be found in this journal. And the good news is you can download it for free with this journal, with this website. So you just write up this website, and if you want to join this International Association of Orthodontic and Implantology, you are welcome to go to the website and register. And the next meeting will be next month in Taipei. We have an annual symposium about ortho and implant. So, once we know the law, what will be the upper? Suppose you have a case like this. Do you need to do sinus lift? Because it's just 2 or 3 millimeters. And the patient did not want to have sinus lift. So you can also apply the same philosophy and move the first premolar backward and create an implant site right here. So after you move, you create an implant site, so you'll be able to get a good volume of bone, so you can avoid sinus lift and sinus graft. And finally, you can put this implant without sinus lift. So it is great to learn this ortho and implant combined. So maybe we should reconsider the role of bone grafting, especially when patients have this male occlusion to start with. We really need to fix that. We cannot just put an implant. So my conclusion would be no sinus lip with this case. It is great to learn this also implant combined. And look at that, when we separate, the papilla will be split to from one papilla to two. So sometimes you will lose a little bit papilla when you restore this. So that's something you needed to know. But fortunately, it's not in the anterior aesthetic area. So I will encourage you to learn this technique with also an implant combined treatment. So you'll be able to get a result like this. So the conclusion for today's lecture is the era of also an implant combined treatment has been arrived. So my dear friend, be part of it. And finally, if I can have 5 minutes, I will have this material and show you what is the future of learning and teaching. And I'm so excited during the past 10 months. I worked with Dr. Parr, Dr. Thomas Han, and Samuel Lee. We try to put everything together so the people who wanted to learn also an implant or any implant surgery will be able to learn in a very fast way. Suppose, when you have the iPad like it, okay, so when you have an iPad like this, you look at, we have a dental implantology new book. And what that says is, when you go to here, I invited Dr. Thomas Han and Dr. Parr and myself to write up this ebook. So on the top, you can see different chapter. You run through different chapter. For example, the 2B, 3D will be in chapter 7. So if you wanted to make a note, you can make a note and also you can change the color. If you have question with those, have problem with those English, you can just touch and get a definition. So in this book, we also build in the dictionary. So you don't need to go back to the dictionary. So with that, if we run through it, we will show you different kind of also implant combined case like this. For this case, for example, if you have a case like this, and if you don't do the ortho, you will end up with maybe 4 implants. But with orthodontic treatment, you'll be able to reduce to 2 implants. But most important, you can change the profile from bimetallous protrusion to a very pleasing profile. That tells you why also implant combined is the way to go. For here, you also can see that Samuel Lee has put up his great material right here, even in this video, that will show you step by step how Samuel Lee performed the sinus lip. So you go to the step 2, step 3, something like that. So everything you wanted to learn, you can just sit in the living room and watch your television and have this iPad and you learn everything about implant. So let's go to like Dr. Parr. He talked about show implant, all the show implant. And finally, he come up with the clinic procedure with different case, the follow-up, the long-term follow-up. So those are very valuable material, which I strongly encourage. And finally, because today we will end up with our great teacher, Thomas Han. So I would like to show you Thomas Han's presentation. Like this. So go to different, you will see that Thomas Sam put on he is a very detailed person. He will show you every facet, how he treat this case. And finally, if you want to look at how he performed the surgery, you just touch that and just enlarge, you will see his FRED procedure. Everything is right in this book. So with that, I want to thank you, my moderator, and all of you, and most important, my mentor, Dr. Parr, to organize this event. Thank you. Thank you.
Thank you, Chris. Please come and have a seat here. So may we switch on the light now? And now the discussion is open. So I would like to have some questions to the speakers. I think that also this last presentation was really very interesting. It showed us the chance to do something different or something new, and maybe to reconsider the approach to the bone reconstruction could be a great idea. Because I think that to have a good orthodontist in your practice could be feasible and could be much easier sometimes than become a great oral surgeon as Roberto is. So things that seems to be very easy when you have a great attitude on doing oral surgery can become more complicated. There is a learning curve. So what Chris teaches us today is to keep in mind how important it is to join different procedure and different considerations. So thank you, Chris, once again. Any questions? Well, if I can tell you... Well, yes, please.
Yes, Dr. Chang. Intruding 9 millimeters of the second molar is very remarkable. That is a very excellent presentation. And my question to you is it routine and it is normal to be able to intrude that much, or is it something that is just a showcase?
No, I think that's routine, but there are two keys you have to remember, that when you intrude the teeth, you're not going to hurry. 1 millimeter per month is good enough. And also when you apply the force, you apply very light force. And every month, you probably need to do scanning. So you eliminate the pocket. So the first, you will create a long junction epithelia, and that will remodeling become a normal situation. Thank you for your question.
How do you prevent those tears irritating the cheek or tongue?
Very good question. How to prevent the screw to irritate the cheek? The best way would be design. Find a good design. The head of the mini screw is rounding and big. Number 2, when you insert it, the position, the angulation, supposed to be a little bit parallel to the long axis of the root. So that will prevent irritation. Thank you. That's a good question.
One more question on the mandibular case where 36 is missing and you're trying to move the 37 forward, and the ridge is kind of resolved and it's narrow. Mm-hmm. Do you still proceed to medialize the second molar to the first molar position, or is there a limitation? How much can you force the movement?
Very good question. And this question has many studies talk about that. Probably the most famous is written by Vincent Kokesh. He talked about the ridge. If the ridge has been resolved 50%, it is impossible to close the space. But what I have learned in my practice, I try to close all the case. And be honest with you, most of my case, I close those space. Even it atrophy to 30% left, I still close the space. But the key is with very slow speed. Don't rush into that. Thank you.
Thank you very much.
Any other question? Thank you for your very complete and quickly reply. My duty as a moderator is to try to give you a couple of tips to take home from those lectures. So if I should say from the first presentation, if I can take a message from their presentation, is what I read between lines is please try to strictly follow the guidelines of the companies. They show us, especially with conical connections, how important is the torque. So there is no chance for us to disrespect the guidelines and to expect to have success. So this is the trick that I can take from the first presentation. And the trick that I can underline from Chris' presentation is something that is really, really a part of my usual lectures. Please try to say always yes to your patient or maybe to your patients. If you say no to your patients, you can make a mistake. Let me explain you very shortly why. If something is impossible for me, if I say to my patient that this solution is impossible, I lose not only the case, but totally the truth of the patient. Because my patient will go to Chris, will find the solution, and will think that I'm totally unable to do my job. So, also if I'm not personally able to do, please keep your door open to some other solution, because some other colleagues can do it. If you say to the patient that I'm probably not able to, but someone else can, and I will bring you by hands to a colleague, you still lose the case that you've already lost, but you keep your patient, and today's problem is more patient retention than everything else. So, let me conclude this section. This is my turn to thank Megagen in general for this kind of invitation and to have done this magnificent job. And I'll let you go to the coffee break, and I invite you to be in time for the next section. Thank you once again to all of you.